So we do have an initial reaction to the fee schedule, which was published. It will actually be finally published at the end of August. Sorry, at the end of July in the Federal Register. But what CMS does, and a whole bunch of other agencies do, is they produce a pre-publication copy to give folks a little bit more time to look at it. They look very different in terms of formatting and that kind of stuff, but it just gives us more of an opportunity to really dive in and try to understand it. So that goes on display. And what's also nice that CMS did is, because of the importance of this regulation, they also produced a whole bunch of background materials, other things explaining what they're trying to accomplish within the fee schedule. So the top line is, we're still bummed. We're still frustrated, seeing red while you try to get in the black. With the cuts in the fee schedule, there is a statutorily mandated 2.8% cut that CMS had to implement based on what Congress gave them for an appropriation and really an entitlement. But the money just wasn't there in order for CMS to do anything but create that cut. So CMS is sort of in a box, and it's why it's so important for folks to engage in congressional advocacy on the payment cut, as well as stuff with CMS. Because Congress sets that rule, right? There's a sort of, the way that it works is Congress produces the skeleton and the regulatory agencies produce the flesh, right? And so this is an expression of that, happens every year, and it's really, really critical to know what it's going to do. So, overall, 2.8% cut across the board for all specialties who use Part B of the Medicare system. So that's physicians, that's nurses, that's a whole bunch of other folks who are in the healthcare profession. That's not hospitals, but it is, the caregivers, I would argue. And so very frustrating. We'll push back against it, like I'd said, with Congress. And then hopefully, just like last year and the year before, we'll be able to blunt that cut and make sure that in the lame duck, that there will be some movement in terms of limiting how bad it is. There are, however, a whole bunch of really good things in this fee schedule, and you might remember the breaking news that we had a little bit back that predicted some of these things, and we got very lucky, or just had very good advocacy. APTA had very good advocacy to get CMS to really take our side of some of these really in the weeds policy choices. And one of them I'd like to highlight actually was one I'd mentioned that may have seemed a little bit in the weeds. There are 19 codes that are often used by PTs that were, impacted by the multiple procedure payment review. And basically what happened is we were successful, APTA was successful at getting CMS to recognize that these physical medicine and rehabilitation codes were misvalued, right? And so APTA produced a great list for these 19 codes and suggested what are known as RVUs, or relative value units, that are associated with the codes, and with even a smaller component of that, the PE expense component of what the RVUs become. So the way it works is, there's RVUs associated with each code, and then there's a couple other modifiers. Then that gets modified or multiplied by what's called the conversion factor, and that gives you a dollar figure, right? So the conversion factor, that 2.8% cut, looks like about $32. But what's really nice is some of the inputs for 16 of these 19 codes went up significantly. So even with that 2.8% cut, you're going to actually see some increases in really commonly used codes. They're not going to be big. And there were 3 that actually are commonly used as well. One very commonly used that went down in value. But overall, even though there's that 2.8% cut, because some of the inputs and what the RVUs will become and then get multiplied by the conversion factor, you're actually going to see, a couple of cents increase. That's not going to track with inflation, but it is certainly better than an almost 3% cut, which again, I'm very hopeful we'll be able to blunt through congressional advocacy. So really good news on those codes. I'm not going to go through each of them here. This chart is on page 179 of the pre-publication copy, and it looks a little misleading because it says that there's the 3 columns. One is the proposed RVUs or RPE percentage. Then there's the ones that the RUC produced, the Relative Value Update Committee, and its subcommittee that deals with misvalued codes, and then APTA proposed ones RVUs or PE inputs that were even higher. And CMS explicitly states in their regulation, we're going to take the middle road. We're not going to go with what we had in the past. We're going to go with what the RUC suggested. And I think having the APTA suggest even higher RVUs really made it easier for them to be in the middle and say, we'll go with the RUC. So you always want to be thinking in negotiation, where's the fallback for folks that probably won't take automatically take the high road, as I would put it. But bottom line, what's going to happen because of those misvalued codes is many of the codes that are used will by PTs will actually be paid marginally higher. Now, again, that's also why it's incredibly important to do effective congressional advocacy on blunting the cut, because if we're able to blunt the cut, those increases will actually be even higher, because the bottom line dollar figure that you get paid for each of those codes, misvalued codes, will increase if we decrease the overall payment cut that others receive. So that's really good news. It's going to be a little counterintuitive, I think, for folks to see when 2025 rolls around, and it's also not guaranteed, right? What we need to do is, in comments to CMS, because this is the draft rule, not the final rule, we need to praise them and thank them and say, you're the best ever because you implemented these misvalued codes increases. Now, we of course would want to say, please take the APTA ones in any future rulemaking. But overall, I would say that's a positive, and it's going to be a little bit of a surprise, I think, to folks that they might actually see increases, very, very small, but marginal increases, and perhaps not decreases, even with the 2.8% cut, which again, we hope to decrease. So again, in the weeds, but I think that's really good news. And I just can't thank APTA enough for the advocacy they did to make that that change. But we've got to keep it, and that's why it's so important to do advocacy. The KX modifier, this is one of the modifiers that is used by PTs very often. That actually increased the threshold for using that modifier, increased to $2,410 for PTs and speech language pathology services. That represents a 3.6% increase. So if you start doing a whole bunch of services for someone, that threshold, when they start looking and auditing that individual's care, actually has increased to 3,000, but it's sort of a gray area or a possible review after 2410. And again, that's for PT services and speech language pathology services combined. Different for occupational therapy, that's its own individual 2410. But what's great is that that's an increase of 3.6%. They recognize that costs are going up, especially for those really sick patients. The PT or the folks who are frequent flyers with PT, who get a lot of PT, they are going to have the opportunity to receive more PT, which we of course think is a good result as a result of that threshold increase. One other thing that I think is just really great is the breakthrough on PTA general supervision. And as you may have known, PTs were really required to be on site for supervision requirements under prior CMS rules. What's really great is that CMS has recognized that they're going to be able to extend care of PTAs by having PTs be available to provide direct oversight. In the past, direct supervision, the PT had to be physically on site while services were delivered. General supervision, which is where we're going to go here, is what the new rule will be if we can keep it. And that requires only that the PT be immediately accessible, but not physically in the office or patient's home with the PTA. This is sort of a 1-2 punch that I'm not totally psyched about, but I think it's such an important pushback on the 15% PTA decrease in payment. And I think this just makes sense with the focus on CMS's advocacy and health equity, right? And health equity, if you think about who receives PTA services, within the country and within the real world, not just within this fee schedule craziness, it's generally folks in rural areas and underserved communities in urban areas. It's not these suburban rings where folks are really getting a lot of PTA services or services provided by PTAs. So if a PT is able to oversee multiple PTAs as opposed to having to be on site, you're going to really see some increases in access. At least that's the hope. And that's really good, right? We're going to get more PT services to more people. The thing that stinks is that 15% decrease in PTA payments is going to impact, that access. So again, I think it's sort of a giving with one hand and taking away with the other. Still, with the patient focus on allowing general supervision, it's an important step forward, and we need to praise CMS for listening to us. That is also a result of this, dance that Congress does with CMS. APTA and others have been very supportive of a piece of legislation that is bipartisan. Looks like it was, on its good way to passage, and CMS sort of beat the Congress to the punch. I still think it's important that we advocate on that legislation to sort of lock in what CMS has to do. This is really a regulation, which is underneath a statute. We want to change the statute too, so it always stays this way, and that general supervision gives away or is allowed, as opposed to this direct supervision structure. But this is the Empower Act, and I think that progress in moving that bill through the congressional process helped to justify CMS as saying, okay, yeah, we can do this on our own anyway. So why don't we go ahead and at least do it? Study what it does, and then be able to provide more information on it. But good news in general supervision versus direct supervision. APTA again got a win there. Burdensome plan of care requirements. It is so frustrating for PTs to need to provide care quickly for folks who, that's the highest quality care is when it's provided quickly after an injury, or you just get the best outcomes, right? When folks are able to get into the PT quickly. And in those instances, sometimes you have to wait on the plan of care being signed off on by the referring clinician, right? Physicians, others, sometimes they sit on those documents, right? And they don't sort of prioritize signing those. And then really the PT is on the hook. They really don't have the authority to provide care until the plan of care is signed off on. That is changing under this new regulation if it becomes final. And so we have to praise CMS for this. There's a new rule on the plan of care requirements, and we're going to comment on this, but basically the way it works is the proposal would allow the physician's signed order or referral to demonstrate initial certification of the PT's plan of care. And that's different than the way it works now, right? PTs must send their plan of care to the referring physician and secure a signature within 30 days, with a PT bearing all the responsibility of getting the signature. Otherwise, the PT has to choose between stopping treatment or proceeding with the risk of not being paid by Medicare. If you can't get that signature, it's really on you whether or not that care will be reimbursed. And if you don't get the signature, it doesn't get reimbursed. So this basically provides a cushion for PTs to be able to provide that care. Again, really strong for patient results. Again, there's such good evidence to show that if folks get PT quickly, they do have better outcomes. So this is a thing that's hopefully going to decrease the risk that PTs have to take providing care to folks when the plan of care is not signed off on. I just think it's critical that happen, and we really need to praise CMS in that. And then the final thing I'd mention is, let's see, I think I may have actually covered everything. Really, the conversion factor is going to be the main focus of our work, and making sure that the conversion factor continues to be decreased, and then we'll see that increase from the misvalued codes analysis hopefully be even more effective. And so I think 2025, even with these continued cuts, might be a better year than 2024 in terms of Medicare payment, as well as some of the administrative burden that folks have to deal with in their practices. So again, conversion factor cut. We also have that information on the cap for the KX modifier. We're also, very happy with the breakthrough on PTA general supervision, and then the plan of care requirements, as well as the misvalued codes. There's a lot to be happy about in this fee schedule, but we have to lock it in and make it final, and certainly not decrease the advocacy that folks are doing on Capitol Hill so effectively, because that is spurring CMS to make some of these changes that they have the authority on their own to make. We need to get Congress to get out of the way and change some of those rules that CMS is locked into in terms of payment. But in the things that CMS had the authority to change on their own under the statute, I think they've done a great job. So kind of a little different than in many instances where we are even more disappointed by the fee schedule. The main thing that stinks is the payment cuts, but again, I think we might see some relief from that this year if we do our advocacy on Capitol Hill right. And we'll hopefully be able to see some better working systems and more money on the table for PTs to run their practices, hire new folks, get more PTAs, help some of those students pay off their loans by offering them perhaps a little bit more, and generally increasing access for PT services throughout the country. So good on you, CMS, for listening to all that APTA advocacy. We have to do our job in Congress and also on the regulatory comments to make sure so many of these good things remain in the final rule. So good news in many instances, but we've got to do our work to push back on how much money Congress is giving to CMS to pay for Medicare Part B's payments.